And now it's time for a short reporting. It's the same case we covered in oral. Can you tell me how to describe it as a short reporting case?
Okay, so this is extra chest frontal projection of a skeletal mature patient. Here I can see that there is mediastinal widening with continuous.
Just tell me, okay, this is not oral. So I am not
Okay.
presented with, okay, just a description. For example, the first item, okay, frontal chest radiograph shows, okay,
Okay.
we start by positive, negative,
So
diagnosis, management in brief sentences.
okay. So mediastinal widening,
Good,
with continuous with the right heart border, left heart border,
good.
and we can see the descending aorta and knuckle through it. So it is anterior mediastinal mass. I can see hilum overlay sign and negative cervicothoracic sign. No pleural fusion.
Negative?
No
If
pleural fusion.
if you are not sure
No,
about positive or negative, don't mention. Okay.
no calcification in it.
Good. Yes.
No mediastinal shift. So final diagnosis is
No, remaining. We will go step by step. Okay. The first item is to mention the positive findings and relate it. So we have a mediastinal mass silhouetting or any of these words should be written. Inseparable from cardiac borders. Having upper aspect fades above the clavicle. Cervicothoracic, positive cervicothoracic. Negatives, no differential density or okay, no internal calcification within the mass. This is a small paragraph. This is regarding the positive. Regarding the negative, complete the report. What do you mean by complete the report? Normal heart, normal bones, no pulmonary nodules. Okay, this is the rest of the report. It's report. It's a short report.
yeah.
Okay, no pulmonary masses, no bony lesions. Cardiac size is not enlarged because sometimes it's borderline. I don't know normal or no. This word is better. Cardiac size is not enlarged. Okay, this is good regarding the report. Positive, negative. Now the diagnosis.
Superior or anterior mediastinal mass, most likely lymphoma.
Good. Management, simple sentence also.
So CT, chest, abdomen, and pelvis. CT, neck, chest, abdomen, and pelvis for staging.
Okay, agreed. Okay, the diagnosis appearance are those of anterior mediastinal mass. Top differential is lymphoma and thymic tumor. Alternatively, we can say findings are suggestive of anterior mediastinal mass, most likely lymphoma, or appearances or features are in keeping with whatever you will write. Okay, anterior mediastinal mass, 1 or 2 differential. Management, I need CT of the thorax with contrast is advised. Okay, sometimes, okay, CT staging is advised and referral to oncology MDT. It's accepted. The second case, the same. Okay.
So
Frontal chest radiograph shows.
well-defined opacity with well-defined lateral borders and with medial border, indistinct medial border. It is showing negative cervicothoracic sign, and
Good.
it is posterior mediastinal mass, and cardiac size is not enlarged. Bones appears normal. There is no ribs widening, no mediastinal shift, no pleural fusion.
Good.
So diagnosis, posterior mediastinal mass. This could be different. I can write differential like neurogenic tumor or esophageal duplication cyst. It could be hematoma.
No need to mention many diagnoses, by the way, in the short reporting. Okay. And management again.
So MR of the same region
Good,
for
good,
confirmation.
good. So again, description first, positive, followed by negative. Mediastinal mass seen projected over the left upper lung zone, having upper border well defined above the clavicle, consistent with negative cervicothoracic, no splaying. About the remaining, no pulmonary bony lesions, no pleural effusion or pneumothorax. This is better to be mentioned in case of trauma and emergency. Cardiac size not enlarged. Finding are suggestive of posterior mediastinal mass. The most likely diagnosis is neurogenic tumor. One diagnosis, one or two. It's accepted. Short reporting. Okay. MRI. Why MRI? Because I'm suspecting a neurogenic tumor. And or contrast enhanced CT of the thorax is advised. Okay. Thank you, ya boss. Inshallah, I
Thank you.
will give you more cases in the next session. Okay.
Thank you so much.
Welcome, welcome. Okay, candidate number 10, if present.
Yes, sir. She's present. Let me unmute her. Okay. Candidate 10, are you with us?
Yes, I'm here. Assalamu alaikum, sir.
عليكم السلام ورحمة الله وبركاته. Okay, boss. Let's start with this case.
X-ray chest frontal projection. The most striking abnormality is the fracture of the right-sided anterior fifth, sixth, and seventh rib.
By the way, I'm sorry to interrupt you. By the way, it's important in short reporting to read the history. Don't
Yes, sir.
forget, read the history, my friends, because the age will be important and the additional information will be important. So we have a frontal chest radiograph. Shows multiple, right? Continue.
Yes, sir. Multiple right-sided rib fractures. There is
Involving?
blunting of the... Sorry, sir?
Involving which ribs?
Sir, involving posterior ribs, right-sided posterior ribs,
Okay.
representing flail chest. I can see
From 5
there is...
to 9. Okay.
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 Sir, I can see there is blunting of the left CP angle. I can see some lucencies in the mediastinum, air lucencies in the mediastinum. This could be due to pneumomediastinum.
Again,
No,
because I didn't write report because of time. We described first the ribs. Okay, this is a positive. And the ribs here are fractured on only one side, but we have at least 4 ribs, maybe 5, by the way. And we have definite blunting of the left angle. I'm not sure about no mediastinum, but no problem. In the exam, if you are suspected linear streaks surround the aortic arch. Good. This is a description regarding the positive. Negative, no pneumothorax. Okay,
yes, sir.
no pulmonary opacities because
Yes.
consolidations and. Okay, and cardiac size not enlarged. Diagnosis and management.
So diagnosis is post-traumatic rib fracture, flail chest, and I would advise CT chest for further evaluation and to see any underlying thoracic injury. I will
Very
refer the
good, very
patient.
good, very good. It's multiple rib fractures, raising the possibility of flail chest. But I'm not sure. The management here, urgent CT scan of the thorax to rule out a flail chest and pneumomediastinum. This will be enough. And of course, urgent referral to the chest MDT. Okay. Even if you don't see, if you are not sure, this is an indication of CT scan, a direct indication of urgent CT scan to detect or to confirm the suspicion of a flail chest. Okay, very good, Yabos, very good. Another case, also emergency. Remember, my friends, chest cases will represent about 50% of short reporting exam. What do you mean by 50%? About 12 to 13 case. So I'm expecting in the exam mediastinal mass. You have to prepare yourself. I'm expecting a pleural mass or pleural thickening. I'm expecting 3 cases roughly, 2 or 3 cases emergency at least. One of them may be trauma. One of them may be child, because children will represent, or pediatric radiographs, 25%. So at least 3 radiographs regarding kids, maybe in trauma, maybe non-accidental injury. Prepare yourself. Just short description and the next step. Like this case, يا boss, chest radiograph, a frontal chest radiograph shows.
Frontal chest radiograph of a child shows left-sided pneumothorax with underlying lung collapse. However,
Good.
no significant mediastinal shift is seen. Air is also seen outlining the thymus, giving sale sign, raising suspicion of pneumomediastinum as well. The right chest appears to be unremarkable. Heart size is normal. This patient needs immediate
lines and the tubes. Lines and the tubes.
Yes,
Okay.
Okay, sir. So I can see that the NG tube is in situ, and I can also see the umbilical artery catheter in place.
It's better to say umbilical catheter, because this was venous. If you are not sure arterial or venous, umbilical catheter. Okay.
Okay, umbilical catheter. Yes.
Good. Diagnosis.
So left-sided pneumothorax. Left-sided pneumothorax
And
with pneumomediastinum.
good. Management.
So this patient needs immediate referral for chest tube intubation.
Excellent.
And further management.
Excellent. You can add also a background of respiratory distress syndrome. Okay. Very good, Yabos. We have 2 emergencies in this case. We have a left-sided pneumothorax for urgent intercostal chest tube placement, and we have also Spinnaker cell sign, thymic Spinnaker cell sign, which denotes pneumomediastinum, in addition to the lines and tubes. I think I ready, but didn't full. So urgent referral, urgent chest tube placement. دكتورة إيمان محمد ما تشخبطيش. And follow up study is advised. Okay, very good, Yapos. So again, my friends, we have to train ourselves about emergency cases, pediatric cases. Thank you, Yapos. The next candidate.
Okay, sir.
Okay, sir. We have candidate 11 with us. I'll ask her to unmute.
Assalamu alaikum, sir.
Alaikum salam wa rahmatullahi wa barakatuh. Okay, from history, 5-year-old child with cough and wheeze. I think I reported it. Okay. So frontal chest radiograph showing description.
A retrocardiac opacity, which is selecting the diaphragm in left lower lobe. There is also some ill-defined opacities or haziness also noted along the right pericardic border. There is there is some tubing seen, also seen.
External lines and the tubes seen. Okay.
Yes, sir. There is no.
volume
there is
loss?
also
With
yes.
volume
There is
loss?
volume. There is blunting of the left CP angle.
Good.
And
So we have retrocardiac triangular opacity containing some air bronchogram. We have blunting left pleural angle, and we have CP angle. Okay, and we have left sided volume loss. Negatives, compensatory hyperinflated right lung. Okay, unremarkable cardiac size, no bony lesions. Diagnosis.
It can be consolidation of the left lower lobe, or it can be collapse and
cough and wheeze. Presentation, cough and wheeze.
Foreign body aspiration.
Yes. So diagnosis is
foreign body aspiration. Further, there will be bronchoscopic retrieval of the foreign body. Is the management of the patient, and it's urgent.
Good. Just to recollect the data, it's not just a foreign body, it's lobar collapse secondary to foreign body. Okay? So findings are in keeping, no problem. We are learning here. We are learning from each other. It's okay. Findings are in keeping with left lower lobe collapse. This is the main diagnosis. Then the most likely diagnosis in this age group, in a 5-year-old aged child, is a foreign body inhalation. What about other causes? Are unlikely. okay, are unlikely in this age group. Next step, urgent CT chest, sorry, and bronchoscopy for foreign body retrieval. Very good. Now another child, 6-year-old child, fever, productive cough. Chest
Okay.
radiograph shows.
There is a well-defined triangular opacity noted in the left retrocardiac region with
Triangular. Triangular. Okay.
There's an opacity. There's an opacity in
Okay.
left
Okay.
retrocardiac region with air bronchograms in it. There's also
Yes.
slitting of the left hemidiaphragm.
Good.
There is also mildly reduced lung volume on the left side.
Good.
And the right lung is normal. There is no other
Normal cardiac
bones are
signs.
normal.
Okay.
Yeah,
And
normal
bones.
cardiac signs. Okay.
Diagnosis.
It's an infective etiology in a child of this age, likely consolidation, or
Good.
my differential may include sequestration, but I will request for the cross-sectional imaging of the patient if the patient is not improved after
You
empirical trial.
lost a lot of marks.
Okay.
CT scan. I didn't. Now it's not oral case. Remember.
Okay.
Why?
Okay.
Fever and cough. It's infection. I didn't say repeated episodes of fever and cough.
Okay. Okay.
You know the difference? Repeated episodes means sequestration or chronically retained foreign body for
Foreign
CT
body.
scan.
Okay.
This is for oral. But now fever and cough, it's very simple common case. So
Okay.
left lower lobe, just left lobe. By the way, the description, as you said, very good. It's retrocardiac opacity, having air bronchogram and associated with silhouetting of the left hemidiaphragm and mild left volume loss, hyperinflated left lung, normal cardiac size, no bony lesions. Findings are suggestive of left lower lobe pneumonia, direct.
Okay.
In my routine practice, I write it like this. Alternatively, it's accepted left lower lobe consolidation. What about the management? Urgent referral to the clinician to start medical treatment and follow-up radiograph after 6 weeks from treatment. Okay,
Okay.
boss. This
Okay.
is a simple report, not oral case. Please, my friends, differentiate between oral and non-oral cases. Good, yeah, boss. Thank you.
Thank you.
The last candidate.
Yes, sir. Us candidate 12, I'll ask her to unmute.
Yes, sir. Assalamu alaikum.
Okay, alaikum salam wa rahmatullahi wa barakatuh. Okay, you can proceed. I didn't write for this one, but I'm with you. Frontal chest
Okay.
radiograph, shortness
Frontal
of
chest.
breath, 5%. Okay.
Okay. Frontal chest radiograph. There is a volume loss on the right side,
Good.
and there is nodular pleural thickening, circumferential nodular pleural thickening, encasing the right lung.
Good.
There is a loss of right cardiac border and right hemidiaphragm,
And
and
some rib
opacity,
crowding. And some rib crowding. Very
and
good.
some crowding, and opacity
Negatives.
is seen in the right CP angle. Negatives, there is the left lung appears unremarkable,
Good.
and bones appears unremarkable. No bony lesion or left pulmonary lesion.
Good.
My likely diagnosis is of the mesothelioma. I like
Okay.
to correlate with any occupational history of asbestos and advise CT thorax, contrast enhanced CT thorax for further evaluation.
Very good. Very good.
And
Very good, Yunus. The
CT
remaining,
discussion.
you described very good as reduced volume of right hemithorax with nodular pleural thickening, circumferentially encasing the right lung, associated with signs of volume loss as rib crowding, elevation, or absent or silhouetting of hemidiaphragm and the right cardiac border and angle. No calcified pleural plaques could be seen on the left lung. This is important. This
Yes.
important point. It's a point of knowledge. Okay,
Yes, yes.
you will take mark for this. Normal left lung field with no calcified pleural plaques, unremarkable bony cage. Diagnosis: right pleural thickening, most likely neoplastic etiology, like mesothelioma. accepted. Okay, for correlation with history, occupational history, and urgent CT, plus or minus biopsy. Okay, we will indicate also biopsy, histopathological correlation and biopsy. Very good, يا boss. I will take another case. Okay. Okay. This one. 28 years old with cough and night sweat. First, it's a chest radiograph. Two mandatory point for correction. Okay. Frontal chest radiograph shows.
Okay. Frontal chest radiograph shows some areas of reticular opacity and nodularity seen in the left upper lung zone, upper and mid lung zone. There is also a mild upward pull of the left hila, and no cavitating lesion is seen. Some
No
nodular.
cavitating
Very
lesions.
sorry. Yeah,
Ah,
there
no.
is, yeah.
Are you sure? Yes.
No,
Okay.
there are some cystic cavitatory lesions
Yes.
noted. Some nodular opacities are also seen in the right upper mid lung zone
Good.
on the right
Good.
side as well. And
Good.
no signs of pleural effusion. Bilateral CP angles are clear.
Good. Diagnosis?
Diagnosis could be likely infective as it's upper lung involvement, so it could be post-primary tuberculosis. We'll like to compare with the previous imaging if available.
Good.
Yes, the night sweats history, so it's likely tuberculosis. And we'll like to compare with previous imaging if available. Otherwise, I will alert the infectious team and will advise isolation of the patient and screening of the
Correct.
close contact and CT thorax to look for the
Yes.
further
Yes.
complications.
I know. In some cases, we write a short sentence of management, and in other cases, a long. No problem. This is full mark, and this is full mark. This case should be correlated with history.
Nice. Yeah.
Very good. Regarding the description, we have a bilateral reticulonodular. It's bilateral. Bilateral reticulonodular, more profound on the left side. And we have left upper zonal cavitary lesions. We have prominent left hila with some pulmonary infiltrates as well. These regarding the positive. Regarding the negative, no pleural effusion, no bony, unremarkable heart, and. Diagnosis, okay. Findings, radiological findings and history are suggestive, and the given history. You should mention the given history here. Okay, radiological findings and the given history are suggestive of pulmonary tuberculosis. Okay, post primary most likely. Management, as you said, urgent referral or urgent convey the findings, and advice immediate isolation of the patient, screening of the relatives, and sputum analysis, sputum culture and sensitivity with CT scan. Full management of tuberculosis should be mentioned. Okay, thank you, boss. So, in summary, my friends, in summary for short reporting case, it's the same way you deal with oral, but in short sentences, in short paragraphs. Okay, the same way of study. We have, alhamdulillah, a plenty of time. It's okay to give two differential, like this case. It's okay. In my usual report, in daily report, I put 2 or maximum 3 according to time. So at first, take just 1 minute or less to comment on the film and to collect everything about this radiograph. Every radiograph, we have 25 radiographs in the exam for about 2 hours. So every radiograph from 4 to 5 minutes. Some radiographs will take only 3 minutes, and other radiographs may necessitate more than 5 minutes. You have to do a time management by training at home first. At home, we should revise at home every diagnosis and the next step. What about mediastinal mass? It will come in the exam. Pleural lesion, it will come in the exam. Emergency, pneumothorax, pneumodiastinum, pneumoperitoneum. One of them come in the exam. Other emergency like aortic dissection or diaphragmatic rupture, it will come in the exam. Okay, we have 12 or 13 cases. It will come most of these pathologies. So prepare yourself. Diagnosis and management. Description is not so important because everyone will describe the common cases. I'm expecting 2 or 3 cases will be so difficult. How to deal with these cases? Please shift the difficult cases till the end of the exam. Don't overthink where is the pathology, it's a hidden case. No, shift it till the end of the exam. If you answered 20 cases, full answer, inshallah, you will pass. The remaining 5 cases, no problem. If I did mistake 1 or 2 or 3 or 4, it's okay. But يعني time management. Any difficult case, any case with very long or multiple findings, please shift it till the end of the exam. Finish the short cases first. Cases with short diagnosis and short differential and short type of management. First, start by the description, positive and important negatives regarding the pathology. Then the rest of the report, bones, heart, and vague terminology. A normal cardiac size, it's accepted. But what about if borderline? This term is better. Cardiac size is not enlarged. If you want to say cardiomegaly, it's okay. Borderline cardiothoracic ratio, alternative words. Then summarize the finding in the form of a single sentence diagnosis. Appearances are off. Findings are suggestive of. In keeping with whatever. Anterior mediastinal mass, the most likely is 1 diagnosis. Or 2, maximum 3. Then steps 1 or 2 or 3 regarding the management. You should start training. Please, time, alhamdulillah, يعني is enough. Time till the exam is enough. See you soon, inshallah, in the next week with musculoskeletal cases and short reporting musculoskeletal system.